So we can just kind of work our way down the line.
Sure.
Okay, and I am being told we are up on Facebook. So,
good morning, Facebook.
Good morning. Good morning to our friends on the WFAA Facebook page. I'm going to wait for 1 second while things kind of get going here. We can make sure that folks have a chance to join us, and then we will begin. Oh, yeah, we're good. Okay. I'm going to try to get to as many of your questions as possible. As many of you know who've joined me before, Dr. Mark Casanova is a familiar face. He's been helping us through this whole pandemic, to understand the evolution in this virus, the disease, COVID-19, and then also now here we are with the vaccine news that we've all been receiving. So Dr. Casanova, thanks so much again for being here. First of all, where are we? Where are we in this whole battle? I know that, we encouraged people not to gather largely for Thanksgiving. Some people still did. We probably, I think it's too early to know whether we are seeing, cases as a result of that. But where do we stand right now, at least in North Texas, Dallas County, with regard to COVID-19 hospitalizations?
Well, the hospitalizations related to COVID-19 have certainly been increasing. And you're right to point out that the Thanksgiving effect is going to be blurred and mixed into what was already an increase in numbers. What we're concerned about is that in the next week to two, we're going to see a sharper increase. And then that will be the Thanksgiving effect, a sharper increase in positive cases, as well as a sharper increase in hospitalizations. We've heard the recent news that on a trauma service area E-wide basis, which is a huge swath of North Texas, that many of our institutions are above 15% hospitalization rate for COVID-19 positive patients. I think what's important to understand is that some of our very large academic centers in Dallas County itself are well above the 20% range. So when you hear that number that we've reached the 15% threshold, that is concerning. But what's even more concerning are the institutions that are well above that.
And so what happens in Texas, based on what the governor has said, what happens in Texas if we reach 7 days of a certain percentage? Can you break that down?
Well, it's unclear what will ultimately happen. What was in his original proclamation is that in that region of the state, restaurant capacity would be rolled back to 50%. And then there's other sort of vague, unclear recommendations as to whether we would then also suspend non-emergent procedures in hospitals and the like. I think what really remains to be seen is just how bad is the situation on the ground, and will those locales reach out to the governor for increased ability to implement more significant restrictions in that area, and that may come to pass. We saw that recently down in the Waco area.
Yeah. So I guess then that means, a lot of people are sort of looking forward to a little bit of hope, a little good news. And, when we heard from Pfizer and Moderna, oh my gosh, we're closer to a vaccine. Oh my gosh, it's 90% effective. Okay, what's next? What are the next steps? Now they're testing, the safety around these vaccines. But, I'm already getting questions about, is this going to be another type of shot vaccine where everyone gets the flu? How is this one different? That's from Robbie. And Robbie, I think that's a valid concern, because we don't, as lay people is what I call us, as regular folks who are not doctors, who are not specialists, we don't understand the vaccine process. So that's why I wanted Dr. Casanova to kind of go over this, because we're actually, you guys, I don't know how many people know this. When you're talking about the Pfizer and the Moderna vaccine, you're talking about one type of vaccine development. When you're talking about what you may have heard with regard to AstraZeneca and Oxford University, that is a different type of vaccine. So that distinction is very important. But, maybe we should just talk about how vaccine works in the body.
Sure. So let's start with the flu vaccine, because I think it's a good, important starting point, and then we can talk about the Pfizer and Moderna vaccine and how those differ, acknowledging that neither one of those vaccine platforms stand any probability or chance of actually giving you an active infection of the flu or COVID-19 respectively. So first of all, the annual flu vaccine, the simplest way I describe it to my patients is as if you were taking the flu bug, walking down the street, you take him, you strip off his overcoat, and that's what you mass produce in a vaccine. So when you get the flu vaccine every year, what we've done is forecasted what the most likely overcoat colors for the season are. Is this going to be a blue, a beige, and a short coat, or a green, a yellow, and a long coat? And that's what we're putting in that vaccine. So what you're getting is the outer coat stimulus of the annual flu vaccine with a hope and anticipation that if we forecast it correctly and it turns out to be a short blue coat, that you're then protected.
That's because, and this is different every year because there's an evolution of the flu.
Exactly. Viruses normally undergo what we refer to as an antigenic drift. So ever so slightly changing their fall colors, if you will, or their outer coat. What the COVID-19 virus did, or the coronavirus 19 did, was it underwent an antigenic shift, which is a much more dramatic alteration, which is what's made it so problematic. So viruses can do that. We saw that, for example, with H1N1. You saw a much more significant shift in its outer coat, which made it so much more infective and able to transmit from one individual to another. So going back to the flu vaccine, if an individual receives a flu vaccine and that night or the next day they have some mild symptoms, typically pretty low grade with the flu, what that tells us is that's actually your body responding to the vaccine, mounting an immune response so that when it recognizes that outer coat, the antigen from the actual flu bug, it's ready to mount a defense. So
it's your immune system fighting.
Correct.
Yeah, or
right.
learning
Your immune
how to
system
fight.
is right. Your immune system is revving up. I think also, and we're going to get to this with the COVID-19 vaccines because it does mount a more significant, robust immune response. When we do get a viral illness, the virus itself is the culprit for triggering many of our immune responses. It can also directly affect many of our organs. It can cause pneumonia in the lungs. It can cause a condition called encephalitis, where the brain is actually inflamed and affected, and a whole myriad of other very serious sequelae. But your fever, those muscle aches, the generally feeling cruddy, that's actually your body. That's your body releasing cytokines, elevating the body temperature, and doing other things to try to actually halt and or kill off the virus itself. So it's a double-edged sword. Part of it is the bug itself, the virus itself. Another part of those side effects are your body. That comes into play, for example, with the annual flu vaccine, that you may have a mild subdued response. It's also possible to have a stroke of bad luck. In other words, if you're getting a flu vaccine in the midst of a flu outbreak in your community, it's possible that that coverage just doesn't have enough time to kick in and you get the flu. Mm-hmm. Now, that's the story with the annual influenza or flu vaccine. Let's shift to at least the Pfizer and Moderna vaccines. I'll take those together because it's the same similar modality. What the
Which
researchers
is different from basically what we've been seeing, flu vaccine or any other vaccine.
Absolutely, and so many other
vaccine sort of technology.
Right, exactly. This is really the principle has been around for a while, but I think this is one of the first widespread applicabilities of, again, taking that flu vaccine or taking that COVID virus, walking down the street, stealing from it its sewing pattern, okay, its blueprint for the coat that it's going to wear, what we call the spike protein. We've all become familiar with this picture of COVID and those little spiky crown-looking things that's on its surface. We call that the spike protein. That's what allows it to attach to our cells, insert its own messengers, RNA and DNA, and then go to work replicating itself, taking over our own cells and turning it into its own factories, and then spitting out literally millions of copies of itself, and then having significant effect on the human body. So what we've done and what the researchers have done is just take the blueprint, what we refer to as messenger RNA, that creates the spike protein. And that's what's actually in the Moderna and Pfizer vaccine. That's injected into your shoulder. That messenger RNA works itself into your cells and does something similar to what many viruses do, which is asks your cells ever so kindly to begin to mass produce or replicate not the virus, but that spike protein, that outer coat or that outer coat marker, if you will. As your body does that, it begins to recognize this as a foreign entity and begins to mount a response to that. But what's unique about using messenger RNA is that response is much more robust. It actually incorporates other components of your immune system, including T cell memory. So when you get that booster 21 days later for the Pfizer vaccine, or I can't quite remember for the Moderna, I apologize. But when you get that booster vaccine, you then get a more significant immune response. And that significant immune response is going to come with flu-like symptoms. So to the question, are we going to get the flu? No, you're not going to get the flu. Are you going to feel crappy? Yes, you are. You're going to get a low-grade fever. You're going to get some myalgia, some muscle aches. That shoulder is going to be sore. But Tylenol or ibuprofen or Aleve is going to help mitigate those. And they tend to be relatively short-lived. It's about that night of that second vaccine. You'll wake up the next morning, feel a bit tired and cruddy, but you'll certainly be able to go back to work.
And this is what we've been kind of seeing, reading, hearing about when it comes to, why am I suffering these side effects from, getting this vaccine with regard to the trials. I listened to another interview with a doctor yesterday who said they kind of likened it to a colonoscopy where it's going to kind of be like uncomfortable and unpleasant, but the protection that it offers sort of outweighs the other part of it.
No, I think that's a really good analogy. So much of life is built on expectations, right? If we have an expectation and an understanding of what we're in for, I think it can really make things more tolerable, but also we just have a better understanding. There's transparency, there's candidness. That old adage when we're giving our 11-year-old their shots at the pediatrician's office, do we really say this is only going to hurt a little bit? Well, it's probably only going to hurt a little bit for that annual flu vaccine. The COVID vaccine is going to cause a few more side effects. The irony is that these side effects are actually a huge positive. Yeah. That's telling you your body is rearing up and ready to go if COVID-19, if the coronavirus makes its way to you. So there's some irony built into that.
And can you explain, because I think a lot of people have said, I'm concerned about having to store it in such a cold temperature. And again, for those of you just joining us, we're talking right now about the Pfizer and Moderna vaccines options, possibilities, I don't know what to call them, candidates, they're vaccine candidates. Why do those have to be stored in such a way and transported in such a way that makes it, almost like a guessing game? Because what happens if it isn't stored at that temperature, and for how long can it be refrigerated at this temperature? I've heard 5 days. Can you explain that part of it?
Sure. So the beauty of the messenger RNA vaccine is its effectiveness and the ability to mount a more robust immune response. The downside is that messenger RNA is a fragile substance, if you will. It's not an inert substance like just a protein that we put in the annual flu vaccine that really can live or not degrade or break down at room temperature. So that's a very stable vaccine that doesn't require fancy storage techniques. Messenger RNA is sort of a delicate molecule and does need to be kept at very cold temperatures, and for the Pfizer vaccine, in super cold temperatures. So the recommendations, and they're slightly different for each because the two have slightly different storage recommendations. The data does suggest that, for example, coming out of a deep freeze, you have a certain window that the vaccine will be stable and effective when delivered to the individual.
And then now, can we switch over and talk about the AstraZeneca Oxford University vaccine candidate? Because I think it's more similar to what we've seen, what we're all used to in terms of a vaccine. But we're hearing less about it, and the numbers suggest it might be, less effective. Can you talk to that a little bit?
Yeah, so that's a great question. And let's talk about effectiveness. If the Pfizer vaccine and Moderna, when deployed on a nationwide, if not worldwide basis, do hold to this 90-ish% effective rate, that's an amazing accomplishment. That's knocking vaccine effectiveness out of the ballpark. We are generally happy or content, if you will, if a vaccine has somewhere in the range of 50 to 60% effectiveness. Some annual flu vaccines will have effectiveness in the range of 30%. And part of that is that forecasting and did we get the right outer coat colors and design for the year for that particular flu vaccine. So some of the initial data, if these vaccines carry a 50 to 60% effectiveness or a little bit higher, in the grand scheme of vaccines, that's still considered to be a positive. I think also, some of these vaccines may end up ultimately having niche roles or niche distributions. So we talked about the struggles with the Pfizer vaccine having super cold temperatures, the Moderna at least having a really cold temperature, and the two-shot series and the logistics behind that. It's possible that into early next year and into the spring, we have other vaccine candidates that come down the pike, and we can get a critical mass of the public vaccinated with one vaccine or another, that the effectiveness difference of 90% to 60% will work itself out in the wash, and we'll still have globally an effective protection of our community, what we refer to as the true herd immunity, not the altered definition of herd immunity that we've been hearing over the last several months. When you hear that phrase, herd immunity, it applies to vaccination of a population to affect community protection, acknowledging that some of us may not get the vaccine for whatever reason, or that some of us who get the vaccine are getting a lower potency vaccine. But at the end of the day, if enough of us are protected and the virus is bouncing around, can't find a host, it eventually dies off.
And I want to talk about the news that came out of the CDC meeting last night with regard to who would get the vaccine first or be offered the vaccine first. And for those of you who are just joining us, you guys have got some great questions, and I see you're sort of answering each other's questions as we go along. So thank you for helping us out, and thank you for listening. Dr. Mark Casanova is president of the Dallas County Medical Society, and he's been kind enough to join us and help us understand vaccine science, really. I know a lot of people go, well, when a vaccine is approved, am I going to get a choice between a vaccine? Or when I go to my local Walgreens or Walmart to get a vaccine, do I have to ask them any questions? Like, is this vaccine or is this that vaccine? What do you tell patients or people who have concerns about that, which hasn't happened yet? We're just preparing.
Right. Yeah. No, actually, that's a really good question. And the answer is going to be somewhat forecasting and prediction of the future, right? So by the time we have an adequate supply of vaccine, really for the masses, that one of the viewers who is not listed in those high priority groups, frontline workers, hospital workers, loved ones who live in nursing homes, are going to their local Walgreens or CVS, we're going to be further down the road. You do need to know. It's extremely important for you to know which vaccine you're getting, because if it's a vaccine that requires a second injection at time point, X, you'll need to make sure that you get that same vaccine. So the state and many states use vaccine tracking databases called MTRAC. So we need to ensure that Bill Jones, who got the Pfizer vaccine on January 30th, gets that Pfizer vaccine on February 21st or 3 weeks later. So that's going to be very important. It is plausible.
Those systems aren't really in place yet. Sorry to interrupt you, but I've been listening and reading, and I think that part of the sort of fear and the worry that comes in with humans is like, well, how's this going to happen? Well, how's that going to? No one's told us how this is all going to work. And I think because those systems are not in place yet.
Right. And there, as one can imagine, there is a lot of work happening behind the scenes. I'm being optimistic. I'll be candid and transparent that I am hopeful and very optimistic that this will work itself out. And for better or worse, it's going to be the timing of the rollout and the supply of the vaccine that's going to give us that opportunity to work this out. So the first wave of vaccine is going to go to very controlled settings where employees in hospitals, for example, nursing homes, where it's going to be an isolated nursing home that gets a vaccine, and their medical director will be able to lay out the sequence of the individuals getting their vaccine and whatnot. So we're going to have that time frame to in essence get the ball rolling, while at the same time ensuring that physicians' offices and family medicine doctors' offices, in your local CVS or Walmart, in maybe a community center in some areas, we create that infrastructure and hone it up to the ability to do this in a both in an expedient fashion, but a safe fashion as well.
Yeah, and you mentioned the groups who basically the CDC, for those of you who may have missed it last night, kind of laid out here's how it's going to go generally. And a lot of these the vaccine will be distributed to states, and then states will go, all right, healthcare workers, here you go. Nursing homes and other residential facilities like that, here you go. And then we'll sort of see a trickle down effect. And the reason being, we want to, of course, protect our healthcare workers so they can continue to treat patients who come in with this and everything else. And at the same time, 40% of deaths in this country have happened inside nursing homes. And so that's the reason, for the trickle down. Sarah's asking a cool research question. And Sarah, I've been seeing your comments, so thank you for being so on point here. With the mRNA COVID vaccine, does research give any information whether there's a time period for effectiveness like the flu vaccine? So I presume that's being looked at, but we don't know yet, right? We don't have that time. We haven't spent that much time in this period
Correct.
yet.
That's a great question. And some of the time frame built into these vaccine studies and what's taken a spell for them to get to the point where they say, okay, we're ready to go request emergency use authorization, is that time frame to not only determine are these effective, and again, the Moderna and Pfizer have demonstrated remarkable efficacy of protecting, but also what's the time frame for anticipated or expected side effects or negative effects based on traditional vaccine science and experience. So they needed to hit those two thresholds. Sarah, I don't have an exact answer for you. I can simply say that, again, the two vaccines, those who received the actual vaccine versus placebo, had remarkably lower incidence of acquiring COVID-19. What can we infer from that? I'm honestly not sure. We need to be careful. Were they already being protected after that very first shot, or was it really meaningfully the booster that did the rest of the work? Probably more information to come on that, and a lot more information to come from a global understanding as we go from, for example, 44,000 individuals in the study group for the Pfizer vaccine, which is technically 22,000 who received the vaccine, the others were placebo, to now rolling it out to hundreds of thousands and then eventually millions.
I do want to address one comment. These comments always make me stop. This is a sales pitch on why you should take a vaccine. Do your own research instead of watching the media tell you what you should do. It's interesting because I'm not a doctor, nor do I ever pretend to be one. But I like something that one doctor said to me recently, which is your body is your business. You're the boss of your own body. So that doctor said, I will respect whatever choice my patients make. It's just like if you have a cancer patient who goes, nope, I don't want chemo, right? We're not trying to convince you. We're just trying to educate people on how this process works, how the distribution might work, and answer your question. So that's why we're here to do that. I don't know if Dr. Casanova has something more to add to that.
Well, I guess my simple response is forgive us, or maybe I won't apologize for doing our job as doctors and in healthcare. Period. One of the roles, it's not just to write out prescriptions or to do a particular surgical intervention, it's to be a teacher. We're providing information, we're providing guidance. Sonia's exactly right. I don't chase patients around my office with a flu vaccine. I give them the information they need. We do discuss the risks and the consequences and the benefits and the alternatives. And at the end of the day, they choose not to take that flu vaccine. That's fine. One question I would pose, however, to the population at large or many individuals is, do you really like the way life is going right now? Okay. Do you really enjoy wearing a mask everywhere you go? Do you really enjoy our recommendations that you shouldn't gather in congregate settings? Did you enjoy the fact that there for a period of time, bars and restaurants weren't open and or have limited capacity? If you don't like those things, you're going to have to ask yourself, which do you like less? That life and the continued existence well into 2021 and beyond, or a vaccine?
Yeah, I think that's a good point. There are a lot of people who are asking about, vaccination and autoimmune disease, vaccination and I have, allergies. Have we worked that out yet? Is that something that gets worked out in the clinical trials?
Right. So the clinical trials do take into consideration the underlying medical history of the individual. So when you participate in one of these trials, they do baseline blood work and evaluation of your own medical history, and then they sort of congregate that data to determine, are there any fallouts in terms of significant effects? Are there particular groups of individuals that may carry certain autoimmune conditions or other medical diagnoses that have increased adverse events? We've not seen that yet. But again, a lot of this gets scaled up as we roll out the vaccine to a much larger population.
Mm-hmm. Okay. When we talk about herd immunity, and I'm just looking at some of the comments, we need, is it roughly 70-ish%?
70-ish, right.
70-ish, yeah. There's no exact black and white ever in science and medicine. So I'm thinking, if in order to establish this type of herd immunity, the number of people will need to sort of buy into the idea of getting a vaccine. And look, I'm a hippie, I'm a yoga teacher, I'm a, meditation teacher, I'm an all natural gal. I have a lot of friends who go, nah, thanks, no. So what is the deal with the vaccine hesitancy in this country right now? Where are we going to need to get it? And, at what point will we be like, okay, things can maybe come back to normal? Because just because these first few batches of people get a vaccine in early, let's say December, January, February, the rest of us are still going to be wearing masks outside. We're still going to be social distancing, et cetera.
Absolutely. It's very important. I'm glad you mentioned that. The first couple to possibly several months of vaccine rollout and distribution will not scratch the surface of safety or us being able to meaningfully change our behaviors of being mindful, being careful, avoiding those congregate settings, wear your mask and whatnot. I think generally speaking, and this is generality, the population likely falls into three categories. You've got those that are eagerly awaiting the vaccine, willing and ready to take it, have confidence in vaccines and healthcare recommendations in general, to include incorporation of mindfulness, exercise, and yoga. And also, hey, by the way, some vaccines to protect you against something that is a significant threat. So that blended response, right? So that's a portion of our society. You've got the other extreme, the anti-vaxxers as they're referred to. I'm not so sure how many of those we're going to get to come around. If you already are fundamentally opposed to an annual flu vaccine that is extraordinarily safe, if you're fundamentally opposed to measles, mumps, rubella, these other vaccines that have well-documented ability to protect not just you and your child, but other people around you. Because remember, this isn't all just about you. I'm sorry to burst bubbles. This is about us. I'm not sure how many of those we're going to get. I think there is a large chunk of individuals who are in the middle. And those individuals in the middle, I think, are a mixture of individuals. I think there are many who just simply have concerns, just very valid, legitimate concerns. Mm-hmm. I wouldn't be surprised if some of them are reaching out to you this morning via communication. Is it safe? Is it going to be effective? Was it rushed? Is this too fast? They probably also, that same group, have legitimate, understandable concerns about COVID-19 itself. So I think it's that middle zone that we're going to need to lead by example, provide reassurance to, transparency from day one. And I think those will be the ones that we'll be able to reach. And at the end of the day, we may scratch the surface with some anti-vaxxers as well.
I feel like with healthcare workers getting it first, I don't know, for me, I'm like, well, look, if my pediatrician is giving, her kids these shots, and if my doctors are doing this for themselves and their families, they're not going to intentionally harm themselves, their families, their loved ones, their relatives, their patients, like all this stuff. So I feel like a little better knowing me, this is just me, myself, speaking as a person, knowing that that's where it's going first. I don't know if that helps anyone else.
Oh, it does. And it's a really interesting point you make that, because part of the rationale with high risk medical workers, by the way, so this isn't going to just be because you have an RN or an MD behind your name that you're going to be in the first wave of getting this vaccine. It's going to be those individuals who we really need to stay healthy in the trenches, and or those individuals who care for very high risk patients. They may not be working in a COVID unit, but maybe they're taking care of a transplant patient who has a very, impacted immune system. We need to ensure that they don't acquire COVID-19 that could then be passed to those individuals. But there is a worked in discussion going on amongst the healthcare community that we are looking to own that first step, to step up to the plate and say, not only, yes, I would appreciate the vaccine to protect myself and my family, but also my patients, but then also to be messengers, to be diplomats, if you will. If you look at the makeup of the Pfizer and the Moderna vaccines, there was a large population of healthcare professionals that made up those, which is also beneficial because, again, many of us are in those front lines and even partook in some of the studies here in Dallas.
So a few people are talking about schools, and then Robert is saying, I've heard that employers may require you to get the vaccine. I mean, I don't see that happening. I feel like that's a rumor. I don't think anyone can mandate a vaccine.
Right. I've not heard of any reliable evidence to suggest that. I know that even amongst the healthcare community, that question has come up. But again, at the end of the day, it's, I'm not sure that that's going to be enforceable.
Yeah, I feel like that's lawsuit central, and I have heard of like airlines, like Qantas Airlines, I feel like has come out and said, look, if you want to fly Qantas, you're going to have to get this vaccine. And, I think that businesses can sort of, is it going to be like this no shirt, no shoes, no service thing? I mean, okay, fine. Well, then you go somewhere else, right? But like, if it's your employer, I don't know. I don't see that happening. Okay, here's a question. Why wait for the hospitals to reach 15% threshold instead of taking major actions to slow the spread?
Great question.
That's a tough question because I think that leans on, what we've already been through. And I think that a lot of people have asked, well, Sonia, do you think that there's going to be another major lockdown? And my inclination is to say highly unlikely that there will be a lockdown like we saw in, March, April. But I think as we're seeing in other states, like it is possible that Texas rolls back and further restricts because of these numbers. But maybe Dr. Casanova, you can speak to that 15% or actually what we're seeing in the last 2 days, 16%.
Right. So the short answer to her question or their question of, well, shouldn't we do this earlier? Should we do something? I think it's a very valid point. I think many of us in public health and in medicine would agree that we've actually been asking for more significant measures earlier and more proactive measures, I should say. But the seat of control and decision-making lies with the governor in our state in this particular case. I think the rationale behind the 15% is to use some sort of marker that the situation on the ground is getting bad enough that if our hospitals in our region are at 15% capacity, that's a clear bellwether marker that, listen, we're not only in trouble right now, but we're heading in the wrong direction. So I'm not sure that answers her question. The question intuitively is correct. I think also what's really important to acknowledge, and I've heard this answer given, and when I first heard it, I thought, well, yes, that makes perfect sense. It was asked of a physician in another locale, do we need a lockdown? And the physician's response was no, because if we just do what we know we need to do, we can avert a lockdown. We can avert rollbacks or whatnot. If we just individually didn't do the massive travel we did at Thanksgiving, if we had already started to dampen down those congregate settings, we could have averted where we are right now. And it's not, the we is not just North Texas, by the way. The we was just us as a nation. So do we need to lock down? No, if we get back to those pandemic commandments of wearing your mask, watching your distance, washing your hands. But then the fourth one is being mindful of those congregate settings. If you engage in a congregate setting, a bar, a restaurant, or very significantly those family friend gatherings, you've just flushed all the efforts you put forth at your Tom Thumb grocery store with wearing your mask down the toilet. Because you can wear that mask all week when you're out and about in the grocery store. You go together for a 2-hour family gathering, and you've wiped it out.
So we have about less than 15 minutes left with Dr. Casanova. I'm going to try to get through as many of these questions as possible. Someone saying, curious about the flu season and if that is putting a double strain on hospitals right now. I've actually heard that because of all the COVID efforts we're taking, that flu numbers are actually relatively low, at least so far.
Yeah, so far so good in terms of the flu season. We've not seen a significant impact. We are seeing flu cases, but it's not like we've seen in years past. So the irony is all of our efforts with COVID-19 seem to be mitigating the transmission of flu.
Okay. There are so many COVID-19 vaccines available. How will we know which one is the safest?
Time.
And they're not technically available yet, just
right.
For the person who wrote that. They haven't been approved by the FDA.
Right. I think time, but the viewer is correct that quite possibly by the summer we'll have a handful. And I think by the summer, we'll have then had months under our belts of vaccine distribution. And also it's important for them to remember that part of the studies and the timing of the studies is safety evaluation. So we'll have an initial sense of safety when these roll out and they're given their authorization. The safety is baked into that decision-making process.
Here's something that we haven't mentioned that's a good question and one that's kept coming up. Will there be a future cost in order to get a vaccine, or will it be covered by the government?
Wonderful question. We hope it's covered by the government.
Yeah, everything I've heard has said it will be free for everyone.
Yeah, I mean, and it goes back to this common theme of investment is what do we ultimately want? If we want life to transition back to normal, realizing it's not going to occur with the snap of a finger, then we have to make those investments. Many of us have to get the vaccine, 70%. The government, if it were so gracious enough to pay for it so it doesn't incur cost, those are the steps that we need to transition back to normalcy.
Tony's saying, I have a sister with special needs who lives in a group home. Any idea when she could get the shot? Is that technically kind of in the same category as the nursing homes? It would be?
Yes, those institutionalized congregate settings or nursing homes or group homes, those with special needs, those are going to be really high on our priority for the public.
Hannah's got a good question. What is the first thing you should do after getting a positive COVID-19 result? Are there supplements or other meds you should take, or how do you treat it basically if you have a mild case and you're just at home?
Right. So the first thing you do with a mild case is you pick up the phone and you call anybody who you are confident and aware that you were around, and you notify them. We can all be our own contact tracers, by the way. So when we as a region in Dallas County and Tarrant County, for example, are at cases well over 1,000 a day, contact tracing becomes very problematic. So be your own contact tracer, notify your loved ones, get rest, plenty of fluids, nourishment, chicken noodle soup, low-grade fevers, Tylenol is fine, or ibuprofen, provided that you don't have allergies. If you have any concerns, you call your doctor. You really just self-monitor your symptoms.
Okay. We've got another one here about the vaccine development process. I love these questions. I've read somewhere that they use new technology to build the vaccine itself. So this is talking about the Pfizer and Moderna vaccines. How does this ensure potential side effects are captured quickly during the development process? I understand the H1N1 vaccine caused narcolepsy in some people, which I didn't know about that. But I don't know. How do you speak to new vaccine, sort of the process of new vaccine development? Although you said it's been around a while, so maybe.
Right. The principle of utilizing messenger RNA in this modality has been a theoretical concept for some time that has actually been used in other settings. Now, this is the largest scale that we've rolled it out. And again, Dr. Fauci spoke to this. We really look at our experience historically with vaccines. When there are side effects, significant side effects, and I don't include low-grade fevers, muscle aches, chills, that flu-like symptom as a significant side effect. That's an effect, and it's ironically a good one. But the neurologic potential effects, the Guillain-Barré syndrome, the transverse myelitis that we heard with one of the other vaccines, though again, not fully vetted out, but those tend to occur early in after the time frame of administration of the vaccine. So again, that's why some of these are coming along slower, if you will, because they're still on their clock of evaluating for potential side effects in the thousands of patients that they're studying. Pfizer did that, Moderna did that. They were just ahead of the curve, so they're coming to potential market sooner. So I hope that answers the question. It's usually within those first 30 days, and oftentimes within days of receiving the vaccine, if one is going to have a very significant but very rare side effect.
And Evan is asking, can you clarify how the vaccine works since the virus can reinfect the body multiple times?
So it's for the Pfizer and the Moderna, it's that incorporation of other components of the immune system, the T cell memory and whatnot. When we talk about our immune system, we're talking about a series of different families of white blood cells, but then also all the different things that these white blood cells do. And you can think of it as a military analogy. You know, you got your Army, you got your Air Force, you got your SEAL team that are going in and targeting approaches. Many vaccines will provide the protection of just one piece of your military, just the Army, just the Marine Corps, just the Air Force. These vaccines are actually bringing in multiple components of your immune system to bear a response. Having said that, we won't know how long that immunity lasts until we've been in it for a spell. So the vaccine studies are not going to allow us to have a predictable time frame of, yes, this protects you for X amount of time. So it's probably going to be well into the end of 2021, into 2022, as we do an analysis to determine, is this, what's the staying power of these vaccines, and will they require ultimate boosters?
Once again, patience. Lisa's got a good question that also keeps coming up a lot. If you've had COVID, is it necessary to get the vaccine?
So great question. We do believe it would be advisable to get the vaccine. I think, again, if you have COVID right now and the vaccines are theoretically coming to bear for the general public, let's say spring, maybe you're not at the front of the line. Maybe you say, hey, others who don't have the vaccine, please go to the front of the line. I had it recently. I'm being very careful. Her question gets to the issue of, can you be reinfected with COVID-19? The answer is yes. The question of what's the average time frame is up for continued exploration and not really debate, but just trying to learn it. So I think ultimately, even if you've had it, it's probably going to be a good idea to get it. You may not need to be at the front of the line if you've had it more recently. If you had it back in March, then yes, maybe you'd want to just go ahead and throw your hat in and say, give it to me as soon as I'm in line.
Something else that Kim is asking about is how do you determine when a COVID positive symptomatic person is no longer contagious? And I think I'm like, ooh, we need to bring up the fact that the CDC just changed its guidelines again, well, not again. I think it's always been 14 days, but let's talk about that. So basically, if you have come in contact with someone who says, hey, I get a phone call, right? Sonia, I tested positive for COVID. And I'm like, oh, great. I had close contact with you, which is never going to happen because I haven't had close contact with anyone. But I would have to then quarantine for 14 days prior. Now the CDC says, well, Sonia, you can actually quarantine for 7 to 10 days, up to 10 days. And if you don't develop symptoms, then you can kind of go about your life. Is that right?
Yeah, that's right. It's been, and again, this is a great example of the fact that the information about COVID-19 and our understanding of it is not stagnant. So we're continuously learning and studying and trying to fine tune our understanding of its transmission, of its behavior pattern, and whatnot. I think the keys are, do you stay asymptomatic in that time frame? And then also it's a reduction in time frame of quarantining with testing based strategy to ensure that you have the green light. And part of it may be based on, okay, what are the needs that you have to shave off 3 days from 10 days to 7 days? If you have a job, if you have an obligation that says, listen, hey, we need you back, then you probably go that 7 days and do a testing-based strategy, so get tested. If you are in a situation where you're saying, okay, listen, I'm working from home, I'm not seeing anybody, does it make a difference between 7 and 10 days? No, probably not. Just ride out the 10 days. So, yeah.
Yeah, I sort of wondered, I was like, is this more about the science or more about us as people being like, we can't stay at home for 14 days. Like my life doesn't allow it. I don't know.
Well, and so I think it's a good chunk of science. And I actually looked at some of these numbers just yesterday at another conference call and meeting. You have this very significant sort of bell-shaped curve of infectivity or viral load and whatnot. It really ramps up, and then you have this decline. Pragmatically, is there also some life factors that are baked into this? Yeah, probably so. But I think I'm comfortable enough in the data that I've seen to support this. I was a little skeptical when I first heard it. I guess it was last week. I just thought to myself, I'm not so sure. But in looking at the data, I'm more confident, especially if you incorporate a testing-based strategy so for your ticket, if you will, to get back to being around others if absolutely necessary.
Yeah, if necessary. Okay, another question. Will vaccines stop the asymptomatic spread?
Yes, they should. If you acquire a vaccine and you have this theoretically 90% effective shield on you, it should reduce the likelihood of getting that. Now, it's also important to remember, even with the annual flu vaccine, it doesn't mean that you won't get it, but if you do get it, you tend to get a milder case. So that would be key. That's all the more reason to get that up to that 70-ish% community vaccination rate.
So someone's saying this is just not enough information, just like COVID, when it first came out, there was not enough information. Y'all, we're all just learning this together. I mean, this is what happens, right?
You're right. There's not enough information, and what all of us wouldn't give for a crystal ball. We are learning about this on a daily basis. So you're right. There's going to be more information to come. But the information we have on the efficacy of the current two candidates for vaccine administration is robust.
So someone who asked, Lily, you asked about the cost. We've already talked about that. This is supposed to, as far as we've heard, right, federal government says it's free to everyone. Ricky's saying, doctor, have you had the vaccine? Ricky, the vaccine is not available for anyone right now, unless you're in a trial. So Dr. Casanova has not had the vaccine.
Well, no, I did actually have it in the trial.
Did you? You're a trial participant?
Yeah, I was a trial participant for the Pfizer vaccine back in September.
I didn't know that.
Yeah, well, not something you just say, hey, I've had it. So I actually can't speak from experience. I'm very gracious to our institution and to my good friend, Dr. Burhi, who ran our Pfizer trials here at our institution. You kind of know if you got the placebo or if you got the real deal. Okay. The placebo is normal saline. And I remember the very first night, September 1st, I went home and I thought, well, I got the dud. And then late in the evening, I leaned against a door frame, felt a little bit of discomfort, and I thought, oh, maybe actually that was the real deal. On September 21st, that night, going to bed, I knew I had the real deal. I had the low-grade fevers, the chills, sore shoulder, and it was really bizarre. It's about 3 o'clock in the morning. It just shut off. But, felt crappy that evening and going to bed.
So did you have to get both?
Yeah, you get both. So you get both. You get the first shot at time point X, and then for the Pfizer, you get the 21-day booster. So it's really the booster. I think many folks are going to get that first vaccine, and it was on par or maybe honestly even less than an annual flu vaccine. The annual flu vaccine will have just mild tenderness. I personally don't really have many symptoms with the annual flu vaccine, which led me to suspect I got the placebo for the first one. The second one, there was no doubt. And colleagues and friends I've spoken to who have been part of the trial, again, to an individual, you know that you got the real deal as opposed to the placebo.
And so does that for you, knowing what you know, being, an expert in this field, do you change anything that you do knowing that?
No,
you got the vaccine?
No, I don't. And Sonia, that's a really great question, because I actually must confess, when I heard that because the Pfizer vaccine data came out first and it said 90% effectiveness, my first thought was, yeah, but that included a lot of healthcare workers and or individuals who stepped up to the plate and said, I want to participate in a research trial. I want to be somebody who contributes to an understanding of the development of a vaccine. So I'm willing to put my arm out and get a needle in it. So one might infer, well, okay, well, then that's a group of individuals who are probably, being really strict, not going places, wearing your mask, doing all those things. But when you actually do a data dive, and the same thing is true for the Moderna vaccine, you see that it really doesn't matter that those individuals at baseline were more careful, because what they said is, we're waiting to see an X number of positive cases. And they got those positive cases with probably folks who were still being diligent, but had gotten the placebo. So no, it doesn't cause me to say, yay, willy-nilly, me Casina, here I come. At least for takeout, yes. But no, I'm still going to do all those same things. I think what it does is it gives me an appreciation and an understanding of what the vaccine feels like, and comfort in promoting it and saying, yes, we are willing to step up. We are willing to take this, and we want you to as well.
Oh my gosh, I did not know that. Okay, we hadn't talked about that. Thank you for sharing that experience. And, I see some of you saying vitamin D and zinc and vitamin C. Yes, you guys, y'all, I'm a health reporter. I've always encouraged everyone to, you got to do that all the time, not just
absolutely.
I didn't.
Right. We didn't touch on that earlier when the person questioned, well, what should we do? Those are very reasonable supplements. I've been taking them, every day through this, at least the D and the vitamin C. I think the caveat is don't rely on just those and say, okay, well, I'm taking my vitamin C and my zinc, and so therefore I can, throw all the other mitigation factors out of the water. You still want to be very careful.
Okay. I'm seeing, let's see, I'm 4 months out and still have antibodies. If you've had COVID, please consider donating plasma.
Yes, please do.
Thank you, Sunday, for making that point. Yeah, we need to make sure that those who can do, that would be helpful. So many great questions. We really appreciate them, you guys. Thank you for taking the time this morning to join in this discussion. Share this with your friends and your family. We do have to hop off. They told me to wrap it up before 7:30. So, Dr. Casanova, is there anything else you want to leave us with? Any final thought?
No, just that closing contemplation for those who are concerned or worried or maybe reserved. Not all things in life are binary choices, but you could make a binary argument about the situation we're in. We either utilize our safety techniques or mitigation measures and a vaccine as part of a package deal to get back to normalcy, or we don't. And if we don't, then we're choosing a continuation of 2020, which I don't believe most folks want from an individual level, from an economic level, even from a spiritual, psychological level.
Yeah. Okay. I have one more question because this is a good one. I like this question. Jennifer is asking, how can this vaccine be more effective than the immunity from getting COVID and recovering? We've been told that the body doesn't make appropriate antibodies for the virus. So, and I think I like this question because of the fact that, I'm a naturalist too often, right? Like, I get my flu shot and I've gotten all the other appropriate vaccinations, but you're like, oh, can't my body just fight this? And what's your response to that? I've seen people on the spectrum. So, I have a friend in ICU right now with COVID right now, today. And I've seen people recover with, mild cases. So can you address Jennifer's question and then we'll will end?
If I understand Jennifer's question, it is a great question. It's if one has had COVID-19 and then therefore has what we would refer to as innate immunity. And that dovetails in with the earlier question about, well, if you've had it, do you need to get a vaccine?
Right.
I think the only honest answer we can give right now is more to come on that. That's the crystal ball answer. We don't have that answer yet. But if you've had it and you've had it relatively recently, and we have a limited number of vaccines, that's probably a situation where you'd say, listen, I may be up for getting it, but I want to learn more about it. Let's get other people in line first before me who have not had the infection and who are at higher risk. Remember, in the States, or at least in our region, we had our first case in March. If I'm doing my Aggie math right, that's 9 months, give or take. That's not a lot of time to learn about long-term immunity. So we're learning on the fly with that question, but it's a great question, Jennifer. I think there are going to be individuals who have innate protection, but again, we need the masses vaccinated, independent of those who have innate protection.
Yeah, if this whole experience has taught me anything, aside from just patience, it's that each body is so different. Like each of our bodies responds to everything so differently. It's so hard to say like this will happen or that will happen. And so when you do have a mass of people who have the same experience, like that to me is just mind blowing. It's almost like touching to me, knowing that people can replicate the same experience in certain human bodies. Anyway, that's my parting thought for the day. Thank you again to Dr. Casanova. You are always so gracious with your time, and thank you for continuing to push us to learn more about this, and I'm sure we'll be seeing you again soon. And thank you everyone for all your great questions. Please do share this conversation with your loved ones. I think that there is a lot of confusion, and so hopefully we were able to clear up some stuff for you today.
Okay.
All right.
And be safe.
Have a good day. Yes, of course. Thank you, guys.